especially presentation by Dr. Saeed, and actually very exciting for me for the newer anti-hypoglycemic drugs. So coming back to my topic, classification of diabetic retinopathy. First thing obviously comes to the mind of why we classify anything. The main reason for classification of diabetic retinopathy is to check the progression of the disease, documentation for continued care, research purposes, medical, legal and indemnity issues, management decisions, follow-up intervals, prognosis and counseling. Unfortunately, in our country, research purposes, medical, legal and indemnity issues are not really, fortunately or unfortunately, they are not here. Apart from that, we can actually classify diabetic retinopathy for our management purposes and follow intervals. So I'm always interested, whenever I actually read anything or try to present anything, I'm always interested in the background and history of what exactly we are presenting. So in 1968, a group of experts met in Early House, Virginia to discuss what was known at the time about the diabetic retinopathy. So they developed a standardized classification of the diabetic retinopathy. That Early House meeting actually was the base of every classification and grew out of that base. That was actually essentially a root of any classification of diabetic retinopathy evolved afterwards. So the next classification comes in for which was the diabetic retinopathy study and then ETDRS, early treatment diabetic retinopathy study. For me, for the practical purposes, there are two classes, NSTDR and STDR. Non-sight-threatening diabetic retinopathy, you go for the metabolic disease control and appropriate follow-ups. For sight-threatening diabetic retinopathy, we need active management of the disease in the form of injections, lasers, more frequent intervals of follow-ups, and obviously in the end surgery. So there are many classifications actually evolved during this period from 1968. Most of them are for the research purposes. The main one which we are, I think, in our part of the world, we are using the ETDRS classification. There are others for the grading of NSC, which is UK based, and Scottish diabetic retinopathy, which is another UK based, and American Association of Ophthalmologists and Royal College. So most of them are actually, I think, it's British classifications. Americans usually kept things very simple. So this is the mixture of, this is International Clinical Disease Severity Scale. This is basically a mixture of all the classification and based mainly on the Wisconsin diabetic retinopathy and the ETDRS. So this is mainly like when you see a patient with with the diabetes, and you see the fundus of that patient as a regular follow-up, and you see a normal retina, then you say you can grade it as a no NPDR or no DR. Once you see a single microaneurysm, you can label it as a mild NPDR, and then so on and so forth. If you see a more microaneurysm, cotton wool spots, some edema, very mild edema, then you probably can call it as a moderate NPDR. And there is a very famous for my colleagues, junior colleagues actually taking the exams, 4-to-1 rule. If you see a patient with a diabetes retinopathy, the 4-to-1 rule is definitely going to be asked. So the 4-to-1 rule is a very simple thing. If you see more than 20 intracranial hemorrhages in each of 4 quadrants, or definite venous bleeding in 2 quadrants, or prominent edema in 1 quadrant. When I was actually taking exams, and actually my postgraduate usually asked me how actually we counted the figure of 20. So, I mean, it's not really necessary for the clinical purposes, and for the exam purposes, you really count it and you say, oh, I see 20 microaneurysms. So you just see it in the quadrants, a lot of microaneurysm, you can label it as a significant one. And then the severe NPDR, in few classifications, they go to the very severe NPDR as well. But International Clinical Disease Severity Scale usually kept it simple again. and then after severe NPDR, they moved on to the proliferative diabetic retinopathy, which is mainly a real challenge for the ophthalmologist. And unfortunately, most of the time, we see patients even after all these enlightenment of the population. We see patients with this stage, or maybe advanced than that. So in this proliferative diabetic retinopathy, we see a new vascularization, vitreous or pre-retinal hemorrhage, severe, and other things. And then there's a advanced diabetic eye disease, which we call it severe PDR, in which we see new vascularization on the disc, on any elsewhere, on the iris. You see persistent vitreous hemorrhages and tractional retinal detachments. And working in a tertiary care hospital, patient from far-flung area usually presents with this kind of picture, and you just ask yourself what we can do about it now. Really feel sorry for them. There are certain general classifications of diabetic retinopathy which we actually been seeing from our medical school time, like the background diabetic retinopathy, we see few dot hemorrhages, exudates and microaneurysm, diabetic maculopathy, pre-proliferative disease in which some venous changes and earmark, and diabetic papillopathy, which is a very rare disease. So that's all about the diabetic retinopathy. Now, diabetic retinopathy classification cannot be accomplished without talking about the macula itself. The main reason and main culprit behind the decreased vision is the macula. It's a fortunate patient having macular edema earlier than the PDR, and they come to us, and then when we pick the disease and treat it accordingly. So this is, clinically significant macular edema is not a classification mainly. It's more of an identification and labeling of the disease for the treatment purposes. So if you see the thickening of the retina at or within 500 micrometer of the center of the macula, or hard exudate at or within 500 micrometer of the center of the macula associated with thickening of adjacent retina, or the zone of retinal thickening, one disc area or larger, any part of which is within one disc diameter of the center of the macula. Anything you see it, and then you can say this is clinically significant macular edema. You don't need an instrument to prove it. You can live with it and start your treatment according to the guidelines and the protocols. So there are certain practical classification of the diabetic maculopathy as well. We can divide it into two classes, focal DME and diffuse DME. Focal diabetic macular edema was initially defined as edema caused by focal leakage of the microaneurysms. Clusters of microaneurysms are usually surrounded by a succinate ring of hard exudates. The good thing is the focal DME, if you see it, you see the culprit microaneurysm, you just laser it and that's it. So which is a wonderful thing about identifying focal diabetic macular edema. Diffuse diabetic macular edema is caused by a generalized breakdown of the inner blood-retinal barrier. Microaneurysms, retinal capillaries, and even arterioles contribute to the leakage. So all microvascular systems start leaking, you get a diffuse diabetic macular edema. Hard exudates are usually not seen in a diffuse DME. So if you see a generalized thickening, then we can call it the diffuse diabetic macular edema. There are certain FFA-based classification as well for the focal and diffuse diabetic macular edema. Eyes with more than and equal to 67% of leakage originating from the microaneurysms were classified as having focal DME. Eyes with microaneurysms leakage between 33 and 66% were determined to have an intermediate DME, and less than 33% microaneurysm leakage were classified as having diffuse DME. So less of the microaneurysm leakage and the more of a diffuse DME is there. So again, there is the International Diabetic Macular Clinical Edema Severity Scale. I'm not going into this lot of writing on it. The only thing I just want to say is that they have actually divided macular edema into three classes of like mild diabetic macular edema, moderate diabetic macular edema, and severe diabetic macular edema. Obviously, when my colleague comes to the treatment point, they usually be helpful. These classifications usually helpful for the management of the patients and for the prognosis. So this is the evolving OCD classification. There is no consensus developed so far for the OCD classification, for the OCD-based classification as such. But I think this is the future of the classification for macular edema. What I feel is the missing in this scale is the ischemic maculopathy, which we can see is from the foveal vascular zone with the help of OCT angiography and fundus fluorescent angiography. Ischemic maculopathy is a very important factor in the management, especially from the surgical point of view. If we can have an idea of this patient is having ischemic macula, there is no point in surgeries or doing a lot of intervention on those patients. Thank you very much.